Today, we're diving into a decision that surgeons have to make that has, well, life or death implications. It's this incredible balancing act between the risk of a massive operation and the promise of a long, healthy life. This is all about one of the most critical intersections in the human body, and what happens when things go seriously wrong there.
So I want you to imagine this for a second. Think of a massive superhighway that's delivering all the fuel, and by fuel I mean oxygen-rich blood, to your brain, your neck, and your arms. It's the most critical supply route in your entire upper body. Now, what happens if a giant, unmovable roadblock just suddenly appears on that highway?
Well, that roadblock is exactly what doctors call Brachiocephalic Artery Disease. It's a blockage in what are literally known as the great vessels, these huge arteries that come directly off the aorta. They're the absolute lifeline for everything from your ability to think to just, lifting your arm.
And the consequences of a blockage like this, they're incredibly serious. We're talking about a direct threat to your brain, which can lead to a massive stroke or a so-called mini-stroke. It can cause just debilitating arm pain, weakness, dizziness, vision problems. This is not some minor plumbing issue. It's a critical failure that forces a really, really big decision.
So, you might be thinking, okay, simple. Just go in and clear the blockage, right? But this is where things get really complicated. The very first challenge a surgeon faces is that, well, not everyone's internal wiring is actually the same.
It turns out the internal roadmap of our own arteries can be pretty different from person to person. So before a surgeon can even dream of choosing a procedure, they have to pore over these detailed scans just to figure out the patient's unique anatomical layout.
And get this, these differences are way more common than you'd think. The normal aortic arch, the one you see in textbooks with 3 separate arteries branching off, that's only in about 75% of people. The most common variation, called the bovine arch, where 2 of the main arteries share a trunk, that's found in up to 27% of us. A surgeon absolutely has to know this before making a single cut.
Okay, so once the anatomy's all mapped out and they know just how bad the disease is, the surgeon finally arrives at the central dilemma. This is the big decision we've been building up to.
It really boils down to 2 completely different philosophies for the repair. You can take what we'll call the direct route, an open chest surgery to fix the problem right at the source. It's a huge operation, but it's built to last. Or you can take the detour, a much less invasive surgery to just create a bypass around the problem, starting from the neck. It's way less risky up front, but maybe not as permanent. Let's break down each one.
All right, let's dive into this first option, the direct route, which is officially known as a transthoracic repair. This is the big one, and this surgery is generally reserved for patients who are younger and healthier. Why? Well, because it involves opening the chest, which is a massive physical event. The patient simply has to be strong enough to handle the stress of the operation itself and the recovery that follows. So what's actually involved? Well, the surgeon makes an incision right through the breastbone. It's a procedure called a sternodomy to get direct access to the heart and the aorta. And from there, they literally build a brand new highway for the blood. They sew a synthetic tube, called a graft, from a healthy part of the aorta to the artery just past the blockage, and boom, full blood flow is restored.
And the data here shows a really clear trade-off. I mean, the risks are significant, with mortality rates creeping up towards 8% and stroke rates as high as 10%. But look at that reward. The 10-year graft patency, that just means the bypass is still open and working perfectly a decade later, is an incredible 94%. So yeah, high risk, but very, very high reward.
But what if the patient isn't young and fit? What if the risk of that huge surgery is just way too high? Well, that brings us to our second option, the detour, or what's called an extra-anatomic repair. This approach is designed for the exact opposite patient profile. We're talking about older folks or people with other significant health problems who just couldn't handle an open chest operation. It's the safer, less invasive path. So instead of opening up the chest, the surgeon makes a small incision up in the neck or near the collarbone. They then use another one of those prosthetic tubes to create the detour, connecting a healthy artery in the neck to an artery in the arm, routing the blood flow completely around that blockage. It's a really clever and a much, much less physically demanding surgery.
And the trade-off here is just crystal clear when you look at the numbers. The immediate risks are so much lower. Mortality and stroke rates are just a fraction of the open chest procedure. But look at that long-term durability. The 10-year patency rate can be as low as 60%. So it's a much safer bet today, but it might not last nearly as long.
So this brings us right to it, the final trade-off. This is the absolute heart of the surgeon's decision, where they have to weigh all of these factors for one single patient sitting in front of them.
And here it is, all laid out side by side. You've got the direct route, best for younger, healthier patients, offers fantastic long-term durability, but it comes with a much higher risk on the day of the operation. Then you have the detour, perfect for older, higher-risk patients. It's much safer during the surgery, but there's a big question mark over how well it's going to hold up a decade from now.
And listen, this isn't just my interpretation. A direct quote from the source material confirms this whole principle. The best surgery isn't about the procedure itself, it's about meticulously matching it to the right patient, especially, as it says, those with severe comorbidities, which is just a medical term for other serious health problems. So, it all comes down to this one fundamental question, one that doctors and patients grapple with every single day. In a decision this big, with stakes this high, how do you balance the danger of right now against the hope for a more stable, lasting tomorrow? It's a profound question, and it's really at the very heart of modern medicine.